Are you able to enable it so that I can screen share and get my PowerPoint up as well?
Let me go ahead and try to, yep, I will make you a co-host and you should be able to do that.
Okay, I also do have a co-host as well. I don't know if it's possible to add him to that as well.
And I don't have the presentation or the program in front of me. Who is the other
that's me. But I mean, I don't need to screen share, so I don't know if you need to necessarily add me as a host then. But
okay. Is Grace all set? Are we all set to go?
Yes, ma'am.
All righty. Thank you so much. All right, I'm just getting my settings up here. Bear with me for a moment. All righty, let's go ahead and jump in then. Make sure I turn my phone off. I don't need that buzzing. Hi, everyone. I appreciate you stopping in today. I am Dr. Palmer, and I'm an assistant professor at the University of Detroit Mercy Counseling and Addiction Studies Department, and I will be presenting with...
I'm Alex Barron. I'm a student and graduate research assistant at the University of Detroit Mercy.
Great. And then today, obviously, you can see by the title, we're going to be talking about conceptualizing mental health issues to mitigate the negative effects that stigma can have on self-concept and self-esteem. There we go. All right, so let me just slide this over here. So stigma, the research on mental health stigmas, obviously, it's well established, and I just put on there a little description of what stigma is, or at least the way we're going to look at it today, is that it's a complex social process of labeling, devaluing, and discrimination. And it is very pervasive. It's associated with mental health issues, and it clearly impacts an individual's self-esteem and self-concept. So while mental health stigma has been extensively researched, research on its impact on self-concept is less established. So we found that kind of interesting. So we're going to go ahead and talk about that today. Now, self-concept and self-esteem, I'm sorry if you guys can see me moving this around, but I want you to be able to see the slides. Alex, are you able to see when I slide this over, or do you just see the PowerPoint so that everybody else can see that as well?
Yeah, no, like we don't see that, like when you move your video panel or whatever, okay. The gallery with the people.
Great, good, I don't want to distract you all. So self-concept and self-esteem, these terms are often used interchangeably, but they're actually very different. So self-concept is really more what you know about yourself. It's a description of your role. It would, something you would hear this described as, I'm beautiful, I'm successful, I'm a good mom, I'm a good friend. And depending on your level of self-esteem, this can be very skewed. In other words, the way that you view yourself or come to know yourself, come to describe yourself. Self-esteem, on the other hand, this is more about what you feel about yourself. So it's different than what you know about yourself. And this is more with regard to self-respect, self-regard. It's the belief in oneself and what they're able to do. It can actually be inflated self-esteem. You can have low self-esteem, you can have high self-esteem. But regardless of what your self-esteem is, it's going to be interconnected to or definitely related to your self-concept. So they are definitely impacted, both of them, by what goes on. All right. So when we talk about the different types of, we talk about self-concept and self-esteem, there is obviously stigma that's related to it. And the three types that we are really focusing on, the three types of stigma associated with an impact on self-concept and self-esteem would be societal, self, and clinician. And public or social stigma, that definitely leads to individuals being ashamed, and they tend to feel separated from the rest of society. And society tends to uphold those negative stereotypes, so it kind of perpetuates that. Let's see here. Once an individual is diagnosed with a mental health disorder, then they tend to internalize that, well, for the self-stigma, but they become very aware of the social stigma that is involved or that surrounds a mental health diagnosis. And as such, they may end up avoiding social interactions, any type of connections with their social environment. They may end up exhibiting less confidence. You may see those feelings of self-esteem begin to decrease, and that ultimately impacts their self-concept, excuse me. So self-stigma or self-stigmatization is another type of stigma that occurs with regard to mental health disorders, mental illness. And this is where they begin to internalize the different types of stereotypes that society believes or ends up, talk about displaying with regard to the individual disorder or the individual. They begin to actually agree with these stereotypes as they internalize it, and they accept it to be true. Due to these negative beliefs, then their self-esteem is impacted, it decreases, and it negatively affects their self-concept. Now, stigma related to clinicians, or clinician stigma, if you will, it's a kind of a hidden stigma. It's not really talked about a lot. And I know as a counselor educator, one of the things that we talk about extensively is trying to help students become aware of their own biases, so that, basically you leave your own feelings and ideas at the door and you walk in and you put the client first. But it can be very difficult to undo a lot of the biases that we grow up with, or ideas that we come to believe is true as well. And research has found that clinicians respond differently to individuals' behaviors and their thoughts and their emotions based on some of their biases that maybe they can't seem to undo, if you will. And borderline personality disorder is one that usually comes to the forefront with regard to this. It's often viewed negatively among clinicians and within the mental health field. I've been a clinician in the field for almost 20 years now, and frequently I've heard other counselors say, oh, I'm working with a borderline patient, do you want to take them? Or someone will want to refer a borderline patient, and they say, nope, I don't want to deal with that, they're too hard, they're emotionally draining, et cetera, et cetera, et cetera. And to an extent, some of it may be related to the stigma that's already been established and perpetuated within society, possibly their own bias if they have any kind of direct relationship with a borderline patient, or it could be just based on experience and different patients that they've already dealt with. The problem in that is some of the ideas with regard to particular disorders tend to get generalized, and then they start to see the disorder as opposed to the individual patient or client. So borderline personality disorder is one of the most negatively viewed mental health illness amongst the mental health profession. One of the things that research also found is that clinicians frequently distance themselves from individuals with borderline personality disorder, and that further serves unintentionally to exacerbate their already fear of rejection and abandonment, and their self-image problems. Now, granted, part of that could be self-protective as well, but the idea that the behaviors are so pervasive, sometimes they tend to minimize, clinicians tend to minimize the behaviors and overlook the individual strengths of the client coming in. So ultimately what this does is they kind of go full circle, and then it exacerbates the symptomatology of the client themselves, and it becomes kind of a self-fulfilling prophecy that the clinician comes in with an idea that the client is going to present with a particular kind of behavior, maybe already have a negative belief about that, or oh my gosh, this is going to be so much work, blah, blah, blah. And then that's exactly the behaviors that the client end up demonstrating or presenting with. So you do get the self-fulfilling prophecy. So this is just an overall view, if you will, of what I've just been talking about. So you have a client present with a mental health disorder, and then public stigma, clinician stigma, and self-stigma begin to interact with this particular disorder on a variety of levels. It can be one of the three, it could be two of the three, it could be all three of them. It'd be great if none of them were involved, but frequently that's not the case, but particularly with public stigma. And then subsequently, the individual's self-concept and self-esteem is impacted. Okay, Alex?
All right. So sort of this labeling and diagnosing that's inherent in the medical model and the DSM. And, you know, although nowadays we're seeing more of a push for like integrated and holistic sort of approaches to conceptualizing mental illness, this definitely historically has not been the case. As the Canadian physician Sir William Osler said, it is much more important to know what sort of patient has a disease than what sort of disease a patient has. And, you know, so before the medical model and conceptualizing and DSM, you know, mental illness was attributed to supernatural and spiritual causes like possession, or you angered the gods or something like that. And in the mid to late 1800s, the government actually pushed for a classification system for mental illness, because in the census data they wanted to quantify what they called insanity. And the precursor to the DSM was actually called the Statistical Manual for the Use of Institutions for the Insane. So it's very much in this pathology-based model, and humanistic psychology and among others have been sort of critical of that. But so the original intent of the DSM and the medical model was really just to provide a shared language for professionals to communicate about these things, and sort of provide more of a phenomenological description of a cluster of symptoms. But it's sort of morphed into now mental illnesses are being treated as almost something that's like physical or absolute and concrete, as opposed to a description of something. It's been treated as an entity on its own.
Good. Sorry about that. I messed up on the slide there. Okay. We're back on track.
Yeah. So this sort of this labeling effect of labeling mental illness can have positive and negative effects, and a lot of the research it's attributed to personal differences. We don't really know why some people are affected negatively and others are more affected positively. But so as we kind of already discussed, people can internalize stereotypes that come from the stigma, and it can become part of their self-concept. So it can go from being somebody that it's I have an alcohol problem to I am an alcoholic, or I am an addict. And and anytime that somebody adopts a belief system about their self-concept, they also take on beliefs and behaviors that go along with that label. Additionally, people can use their mental illness sort of as a justification or rationalization for engaging in maladaptive behaviors, and they can externalize the cause to their illness. And I mean that can also have positive effect, externalizing, but it can also have negative in that it decreases individuals like self-efficacy and taking responsibility. And you know, there's a lot of stigma, you know, like stomp out stigma, and it's pretty much it's a very much a topic in the mental health zeitgeist now. But in my opinion, it's not addressing things at the source, which is, you know, how we're conceptualizing and viewing mental illness. It's more intervening, attempting to intervene downstream. We're saying, hey guys, like don't stigmatize mental illness, you know, don't do that. But by the very act of how we're conceptualizing and labeling mental illness, it creates the stigma. So I don't think it's a very effective sort of PR campaign personally. But and then there's also positive effects to stigma. I mean, to labeling. You know, it can move people from a place of the unknown to the known. You know, it can be a relief. You know, better the devil that you know, kind of thing. You know, a lot of times people who could be experiencing, you know, for example, symptoms of clinical depression, loss of interest, loss of appetite, trouble sleeping, low mood, low energy, things like that. And you know, you give them some sort of assessment, like a BDI or some sort of depression assessment, and just finding out that they have this mental illness, you know, or whatever, it can be a relief to them. And then it can encourage treatment seeking and, you know, or medication. They might, you know, get the help that they otherwise wouldn't get. So, you know, that's obviously a good thing. And, you know, if a label is viewed with social understanding, then that can foster social acceptance for individuals who are mentally ill. So, you know, and then obviously labeling is a key part of how our mental health system functions now in terms of processing, you know, insurance claims, informing research, and, you know, government policies. Yeah, okay. So, so we know that, you know, that labels influence reality, and that, you know, expectancy can become a self-fulfilling prophecy. Yeah, this goes as far back as Rosenthal's famous experiments with the teachers and the students, when he told the teachers that some students were gifted, even though they just measured average IQ. Then, you know, those students subsequently performed better in the class, even though just based on the teacher's belief about them, not based on their actual IQ capacity. You know, and so what some of the research has shown about the labeling effect is that, you know, people have ideas about what it means to be mentally ill, then they might internalize that and display those, you know, poor coping strategies, say withdrawal or expecting rejection. Then, you know, they can act in a way that fosters those very things that they're fearing, and it can turn into a self-fulfilling prophecy. You know, some research conducted has shown that people are less likely to want to interact with people who have a mental illness than don't. You can go to the next slide. So what now? So, you know, we've talked about how labels can negatively influence self-concept and self-esteem. So, you know, what can we do to avoid that? How can we still sort of contend with these mental health things in a way that's not pathologizing? So we're going to talk about sort of a more integrated and holistic approach that can blend features of Eastern and Western thinking, along with transpersonal psychology. And I'll turn it back over to you, Dr. Palmer. You're muted.
Thank you. Boy, I'm pretty good with technology, and today you wouldn't quite know it. So hang in there, I'm getting there. So when we're talking about how conceptualizations differ, we're really looking at, how do you see the client? How do you perceive what's going on with them? How are we going to pursue with assessment? How are we going to interpret what's going on? Is it going to be a description? Is it going to be a diagnosis? Are we going to develop a plan going forward, or a treatment plan going forward? what are we going to do? And just similarly to different theoretical orientations, this is also another way of conceptualizing an individual, what's going on with them. And initially, when we started looking at a lot of this, there's so many moving pieces to this where it was honestly kind of difficult to hone this in down to three, narrow this down to three, because there's such a difference between Eastern and Western, and then there were features of transpersonal that was really different between the two of those. So just to talk about how they do differ in terms of really looking at an individual and trying to assess what's going on with them, kind of put yourself, almost like putting yourself in your client's worldview or patient's worldview. Sorry, I'll use them interchangeably. But we're going to do this with regard to a philosophical approach, trying to really get a sense or feel of what's going on from these three different perspectives. So the Eastern philosophical approach really looks at an individual as a mind, body, spirit entity. It's one. It's not separated as a more Western approach would look at it. That it comes from the same energy source, if you will. It's focused on proactive behavior and individuals being very self-directed in self-care. So we're talking about treatments or what you would do to make yourself feel better. It's really self-directed in terms of meditation, yoga, any type of activities that an individual can do on their own to help themselves feel better. And to engage this mind, body, spirit, self-healing mechanism, they really focus on balancing the body's energy fields and ridding it of energy blockages. So this is where you may hear a lot about chakras, or chakras, however you want to say that. I'm sure one of them that I'm saying is probably not correct, but I'll refer to it as chakras. But when you have your chakras in alignment and you're able to help energy move through that so that you are able to be more connected to source and have a sense of well-being and peace. Also related to that would be any type of reference to energy frequency and vibrations, which are very connected as well. So the focus on what may be going on, a real good example right now with the pandemic going on is there's obviously a lot of anxiety and difficulty with people managing what's going on within themselves at this time. And to be very present and mindful of what's going on within ourselves, it would be very typical or expected for an individual to be able to really tune into what's going on with oneself and then be able to engage in some techniques that would allow them to incorporate self-care into improving the way they were feeling, a more a healthy approach or well-being approach to being able to manage the discomfort, or like I try to say to clients and students and myself, find a way to be comfortable in the moment with the discomfort, because we can't change things. We can only do what we can to help take care of ourselves. Now, very different from that would be a Western philosophical conceptualization of what would be going on in an individual, because the view is typically that the mind and body is split. And actually, I'm going to just side note this for a minute. We are definitely, and just in case I forget to say this later, not trying to say that this is not a good conceptualization, and we'll get to that in a little bit. Each of them has benefits, pros and cons. So, but the Western typical way of viewing an individual's mental health issue is that the mind and body are separate. They're split. They're not one entity per se to be able to evaluate. So they tend to treat the physical body or the symptoms, and the approach is to fix the body, which is really focused on the physiological aspect, very much like you would if you went into a medical facility. You know, if you have heart problems, they're going to focus on the symptomatology and focus on that and work on that to help heal you. Whereas from a different approach, it's not necessarily, there's a separate belief that the symptomatology is being manifested from a different source. So coming back to that, the acknowledgement of energy fields or spirituality or any of this connection to source is really not even acknowledged in this perspective. So it's focused more so on treatments, electric shock treatments, psychopharmacology, and frequently, more often than not, at least in my private practice, is that clients would prefer not to look at this as a frontline treatment or first-line treatment. However, the Western philosophy also is very insight-oriented with any type of counseling, particularly cognitive behavioral therapy is one of the most widely used and evidence-based to help reduce or alleviate some of the individual's mental distress. So then we can also take a peek at transpersonal psychology. And, you know, there's a whole bunch of stuff that we're not even going to get into about that. But there are so many wonderful things about transpersonal psychology that we want to pull in some of these features with regard to this approach that we're talking about. So trans really refers to going across, beyond, through, very expansive. It's not so much limited, which I think is why they've had such a difficult time really coming up with an accepted description of the field, or like I said, we won't get into all that. So they really spend more time focusing on consciousness and the inclusion of spirituality as well, and mental health. Focusing more on growth and well-being versus deficits and pathology. So that aspect is very similar to the Eastern philosophical approach, but it is a very different way to conceptualize mental health issues, although there is a component of Western philosophy integrated into that. Interestingly enough, with regard to consciousness studies and Stanislav Grof, I apologize if I'm saying that wrong, but that's always the way I've referred to him. A lot of his early research on consciousness studies, where a lot of the transpersonal psychology field really took off, you know, it was kind of not necessarily respected or revered in that time back in the 70s. But it's gone full circle. And recently the FDA has approved MDMA for treatment of PTSD, as well as psilocybin for treatment of depression. And prior to that, the utilization of drugs to expand consciousness was not really considered a valid treatment for mental health issues. So as you can see, they're all very different. Transpersonal psychology really focusing more on consciousness, spirituality, and mental health, where the Western medical model approach or focus is mind, body is separate, more pathology focused so that we can diagnose and treat. And then the Eastern philosophical approach, where the mind, body, spirit concept or idea, they're interconnected. So you can't separate them and treat one without treating the other. Okay, Alex? Oh, no, I'm sorry. I'll continue with this. So this is an example, if you will, of how this may look in the Western culture's medical model focused approach. On the upper left, we just added some symptomatology. Maybe a client is scared all the time, or they're unable to stop drinking. Maybe they can't stop washing their hands. They may not want to get out of bed. Their self-concept at that point may be that something's wrong with them. I'm so sorry. There goes my dog in the background. But they may see themselves, you know, as weak. When we talked about the self-concept with the I am and their roles and the way they see themselves. I am weak. I'm unhealthy. Something's wrong with me. They may internalize it and become one with the disorder in terms of I am sick. I am an alcoholic, as opposed to I'm struggling with alcoholism, or that I am mentally ill, as opposed to I'm struggling with a mental illness. Subsequently, the individual's self-esteem is going to be more negative in focus. They may be more anxious and feel inferior and overall just unhappy. And if they come in for any type of mental health treatment or wanting some help with their mental health distress, and we look at that through a Western conceptualization approach, obviously we're going to focus on the medical model, bring out our handy dandy DSM-5, and determine what could potentially be wrong from a diagnostic criteria, using diagnostic criteria to diagnose, pathologize, and label the symptomatology. And subsequently, that could elicit or reinforce stigma, whether it be self or public stigma, and further exacerbate their self-esteem and self-concept. Really sorry about my dog in the background. I thought that was not going to be an issue. Let's look at this now from an Eastern possible transpersonal psychology focused approach. And we're going to look at the same symptoms up on the upper left part of the screen. However, if their self-concept is a little bit more empowered, if we look at something more from a different, not pathologized point of view, they may end up seeing themselves as more empowered, faithful, maybe that they're struggling, but that they're not the disorder themselves, they have not internalized it, that they have mind over matter, that I'm a strong individual, I am capable, I can beat this type of thing. So those are the personal statements that they may present with. Their self-esteem may be more resilient, positive, and happy. And the type of clients, I tend to have two different types of clients that walk in. One that is specifically interested in a more Eastern philosophical approach, non-pathologized, non-psychopharmacological approach. And they do present with a different self-concept and different sense of self-esteem, and they don't like the idea of being labeled or pathologized. And they do have a more resilient, positive self-esteem, even walking in the door, that they're able to manage a lot of this on their own. If you give me the tips and the tools, I'm a very competent individual. I can incorporate a lot of this and really manage a lot of these symptoms on my own. So when we incorporate or utilize this type of approach to conceptualize an individual's mental health issues, it may not necessarily be a diagnostic pathologizing type of label, but we would describe or interpret the symptoms that are going on. Like we mentioned, talking about from a mind, body, spirit point of view, and the person is not the illness. So we focus on what they're experiencing as opposed to interpreting the two as one. And the goal is to hopefully facilitate more positivity, hope, thoughts of wellness, and enhance their self-esteem and self-concept. And the way that this would play out overall, if you want to have kind of a flow chart to talk about, you have the individual that comes in where their symptomatology. And the way that we have kind of looked at this and put this together is that it's much more effective if you put it all together, is instead of trying to use one without the other, right? So the Western lens or the medical model, we need that, particularly in the US. If we're going to reimburse for insurance, we need to be able to use the DSM and diagnose appropriately or accordingly. If they need medication, we need to ascribe to this particular philosophical approach as well. So we diagnose, we have a common language within the different disciplines to be able to discuss what's going on. However, if this can more primarily or predominantly stay within the clinical sector, to look at it more from a medical model, and then when we are approaching or working with the client, try and shift that perspective a little bit and then take on the philosophical approach of an Eastern transpersonal perspective in terms of interpreting or describing the particular symptoms that the individual is presenting with, and look at it more from a wholeness or wellness-based approach to help mitigate the stigma that could potentially be involved with pathologizing or labeling or diagnosing the behavior. So just to clarify, it actually does both, but almost as though you would come in first utilizing the model that we're very accustomed to. But then when you are working with a client, taking a different approach to hopefully reduce some of the stigma associated with the pathologizing aspect of the labeling and diagnosing. Not to say it's bad, because everything has a place and everything is good in its own. But we think that this would be a really great approach to integrate all three of those different ways of, like I said, conceptualizing an individual's problems and helping that client feel more empowered, have a more positive view of what's going on within themselves, and promote healing. Let's see, so that is pretty much what I have and we have from the PowerPoint. Alex, I wanted to pipe in. Did you have anything else that you wanted to add that I might have missed or didn't cover?
Well, I think people probably know this, but you mentioned the kind of like the approval of some studies with psilocybin and MDMA, but like those substances haven't, well, outside of Colorado, but it's mostly just been approved for studies, not necessarily for like treatment. You know what I mean? Yeah, so it's not at that
Thank you
point
for
yet.
clarifying that.
But
yeah, for sure. Thank you for clarifying that. Okay, well, I think we can open it up then. If anybody has any comments, I'm kind of struggling here with trying to figure out what I'm doing with my screen. So does anybody have any comments or questions, feedback? I can't see my participants. Alex, are you able to see them?
yeah.
All right, if you see anybody raise their hand with comments or feedback, can you?
I think if anybody has
let
comments or
them
feedback,
type in?
they can just unmute their mic and they can just talk, right?
True, very good point. I'd love to hear what anybody has to say about this, though. Any feedback, things that we can think about, anything that you can offer. No? Oh, there we go. There's all my participants. Okay, well, I guess if nobody has any comments or questions at that point, then I guess we'll end up just closing early. I was hoping we'd have a little bit of feedback, but if there's no, oh, good. What do we got here? I agree with most of this information. I'm also an MPH graduate. Excellent. Do you have any feedback that you can offer? Any shared ideas? Suggestions? Tammy? No? Okay. Anybody else? All right, well, thank you all for joining us and listening. And if you have any feedback, if you don't want to provide it here and you'd prefer to maybe share it anonymously, we would really welcome any other ideas to think about or consider any ways that we can improve upon the different ideas that we're looking at. Clearly, thank you very much. I appreciate that comment, that it was a good presentation and you enjoyed it. Let's see, I personally don't believe in the medicine world. However, they've seen in the psych hospital how both have worked together. Tammy, exactly. Very good point for pointing that out. So yeah, obviously we haven't had an opportunity to focus on a lot of the treatment, but more just kind of a way to overview what's going on with individuals. Great, thank you all. I appreciate you being here.
I know that you were saying that if anyone wanted to reach out to you, maybe you want to provide your email on the chat so anyone can reach out to you.
Absolutely. Thank you so much.
Also, if there's anyone in the room right now that is looking to get CE credit, you must complete the CE evaluation by April 19th to get the credit. The link is on the last page of our program, if you're looking for it, all right?
Great. Alex, do you want to go ahead and add your email as well in case anybody wants to email you directly too?
Yeah, sure.
Just put that in the chat.
And thank you so much for both presenting today. It was wonderful.
Thank you. We appreciate the opportunity. It's a topic that's very near and dear to our heart. So it's great to be able to share the information that we've come up with. Okay. Did we go ahead and end the meeting? I'm not quite sure.